Hello. Good morning, all of you. Today I am going to discuss antenatal case sheet with you all. How to write an antenatal case sheet. So let's begin the class. So what is the definition of an antenatal care? Antenatal care is a systematic supervision of a woman during pregnancy. And what does that antenatal care comprise of? It comprises of careful history taking, examination of the patient, both examination of both general as well as obstetrical examination. So it consists of careful history taking and examination, and to investigate the woman about any complications if she is having, and finally the advice usually due to the woman. All these three, they comprise of antenatal care. So why do you think is antenatal care necessary? What is the importance of antenatal care in a pregnant woman? It is so that you have to reduce the maternal mortality and morbidity. So how do you actually reduce the maternal mortality and morbidity? By screening for high-risk cases. When the woman first comes to you in the first visit itself, you have to screen her for any high-risk factors, and to prevent, to detect and treat any complication that arises at the earliest. And you have to, and whenever she comes for a visit, there is a continuity maintained from her previous visits to the next visit, so that we will know what are the risk factors or the new complications that are arising this time, and to treat them. It is continued risk assessment and provide ongoing preventive health care. So this is why antenatal care is very, very necessary for the prevention of maternal mortality. And not only that, you also need to educate the mother about the physiological changes that are taking place during pregnancy. What is the definition of labor and how labor takes place with the help of charts, diagrams, and by demonstrations. And all these, when you educate the mother, these are called mothercraft classes, which will remove the fear from the minds of the mother and improve the psychological state, because pregnancy is a high stress situation. So you need to even psychologically counsel the mother. And not only that, you have to discuss with the couple about the place, time, and how the delivery is going to take place, the mode of delivery. Not only that, again, you have to even motivate the couple for the need for family planning methods, and also regarding the appropriate family planning method which the couple need to adopt. You will give advice even about this. Next, what is the objective of all this antenatal care? The objective is finally to achieve a normal pregnancy with the delivery of a healthy baby from a healthy mother. So the objective is to achieve a normal pregnancy. And what do you mean by a normal pregnancy? Anybody? Can you tell me what do you mean by normal pregnancy? Normal pregnancy is, what is the criteria for the normal pregnancy? It is delivery of a single baby. Only a single baby should be delivered. Yes. Okay, vaginal route, term, any other? Single baby, yes. Yes, no instrument should be used. Okay, vertex presentation. Okay, vertex presentation. So the criteria for a normal pregnancy is she should be delivering a single baby, and baby should be in the good condition, and pregnancy should take place at term. Term means between 38 to 42 weeks is called a term pregnancy, and the fetal weight should be greater than or equal to 2.5 kgs. and there should be no maternal complications, which is very, very important. Like if we resort to any forceps or Ventouse, or either if the pregnancy ends up in cesarean section, then it is not normal one. Hence, normal pregnancy is a retrospective term. We can only say that the pregnancy is normal once it is completed. Next one. And what is the procedure we have to follow during the first visit when the antenatal case comes to you for the first time? The objectives are to assess the health status of the mother and the fetus, to see how is the mother and the fetus, any risk factors. Next is to assess the gestational age, and we have to offer her investigations, baseline investigations, and we have to, not only that, we should ensure that this continues. This care is continued even throughout her pregnancy. We have to organize for a continued obstetric care and risk assessment throughout her pregnancy. We have to make sure that she receives treatment throughout her pregnancy. So this is what we have to ensure when she comes to us for the first time. Now let's see what we have to take in the history. Next is history. So how do you start your history? You'll start with vital statistics like what is the name, what is her name, what is when and you have to even note down the date of her first examination, the day when she came to you for the first time, what is her address, what is her age, what is the importance of address in an antenatal care? Yes, so that we will know, because from which place she is hailing, we will know what are the endemic diseases to that area. Not epidemic, diseases that are endemic to certain areas. Certain areas will have iron deficiency, certain areas will have in more amount of fluorine or fluorine in them, so that we will know by the address from which area she is coming, whether she is prone to anemia or any other diseases which are endemic to that region. So that is the importance of address. Next, age. Age is important because if the woman is either in teenage or elderly, she needs again special care. She has to be assessed for risk factors often. So extremes of age are obstetric risk factors, and teenage and elderly pregnancies, they need to be seen with a special care. So that is the importance of age. Next is, when do we call a woman an elderly primary gravida? When the woman has her first pregnancy at the age of 30 years or more, she is called an elderly primary gravida. Why do you want to know whether the woman is elderly primary or not? Because there are certain conditions which are associated to increasing age of the mother. Can you tell me any one condition which is increased with increasing age? Yeah, Down syndrome. Again, good. Next, any other? Fibroids. The fibroids is not that common. Any other thing you can think about? Another is multiple pregnancy. Twinning or multiple pregnancy is more common as the mother age increases. So one is Down syndrome, next is twinning, and there are few more things. Okay, next, Gravida. What is Gravida and what is parity? Gravida means it is the pregnant state, both past and present, irrespective of the period of gestation. She can be 2 months. She could have aborted at 2 months of amenorrhea, or she could have continued her pregnancy till the period of viability, that is 28 weeks, and then it might end up in preterm, or it could be a full-term pregnancy, normal pregnancy. So irrespective of whether it's an abortion, miscarriage, or preterm or term pregnancy, everything will come under Gravida. What is parity? Parity is the state of previous pregnancy beyond the period of viability. Only when the pregnancy crosses the period of viability, you can count her in parity. Otherwise, she will be only counted in gravida but not in parity. So, if the obstetric history is denoted by 2 digits such as P2 plus 1, the first digit will tell you the number of viable births and second digit will tell you the number of abortions. Different institutions will follow different way of representing this gravidity and parity. So some institutions might follow only P with 2 digits which are attached by a plus sign. So first in such cases, in this case, the first digit will indicate the number of viable births, that is 2 in this case, and the second one will indicate the number of abortions. So in some institutions, some people will follow this denotion of 4 digits, that is P, which are in joined by this hyphen. P, A, B, C, D. P is the parity, A is the number of term pregnancies, that is between 37 to 42 weeks. Next, B is the number of preterm pregnancies, that is 28 to 37 weeks. C is the number of miscarriages, that is less than 28 weeks. And D is the number of children that are alive at present. So some institutions will follow this notion. Some will indicate the number of term pregnancies or all the pregnancies by G. Some will denote it with two digits, some people will denote with 4 digits. And who is a grand multipara? Grand multipara is any pregnant woman with previous history of greater than or equal to 4 births is considered as a grand multipara. And what is the importance of grand multipara? They are mostly associated with some obstetric complications which have to be taken care of. So this is the terminology. Who is a nullipara? Nullipara is the person who a woman who have never completed a pregnancy to the stage of viability is considered as a nullipara. She may or may not have aborted previously. Even if she have aborted, but she hasn't gone to a stage of viability. The pregnancy has never gone to the stage of viability. Even such woman who has conceived but where the pregnancy has not gone to a stage of viability is considered as nullipara. Primipara is one who has delivered one viable child. Parity is not increased even if the fetuses are twins or triplets or quadruplets. So even if she gives birth to twins, we will write as para 1 live 2. Then a multigravida. Multigravida is one who has been previously pregnant. She could have aborted a baby or have delivered a viable baby. That she is considered as multigravida. Next, who is a parturient? Parturient is a woman who is in the state of labor. And nulligravida is a woman who has never been pregnant at all. Then that woman is called as nulligravida. Next, who is a primigravida? There is a difference between gravidity and parity. So, who is a primigravida? The one who is pregnant for the first time is primigravida. Primipara is who has delivered one viable child. Primigravida is who is pregnant for the first time. Next, multipara is, here multigravida is one who has been previously pregnant. Multipara is one who has completed 2 or more pregnancies to the stage of viability. Is considered as multipara. And who is a puerperia? She is a woman who has just given birth to a child. Next in the history, we will continue. You have to find out the duration of marriage. What is the importance of duration? It will tell us about the fertility of the patient and the fecundity. What is fecundity? Is how often can the woman get pregnant? Is termed as fecundity. Low fecundity is when the pregnancy occurs after a long time after marriage, where there is no history of any contraceptive use. Without any history of contraceptive use, if the woman conceives and this conception happens long after marriage, then it is low, the woman is considered to be of low fecundity, and she may not get pregnant often. So later on, then she has to be, then this is important because you need to give her contraceptive advice later on. So keeping this in mind, we have to advise her regarding contraceptives once her pregnancy is completed. Next, high fecundity is when a pregnancy occurs soon after the marriage. Then a woman is said to be of high fecundity. Next, religion. Religion is important because there are various practices which take place in certain religions. So in order to know those practices, we need to know about the religion of the woman. Next is occupation. Occupation is, how is occupation important? Because it will help the woman to plan her pregnancy. It will help in interpreting the symptoms of fatigue, like if she is doing excess physical work, stress, or if there are any occupational hazards because of the work she is doing, you have to advise her accordingly. Next is the occupation of the husband. Why is the occupation of the husband important? Because occupation of the husband will give you an idea about the socio-economic condition of the patient. If the woman is of low socioeconomic low socioeconomic status, then we can anticipate problems like anemia, preeclampsia, or prematurity of the baby in this present pregnancy, and we have to treat and plan her pregnancy accordingly. So we need to know about the socioeconomic status of the patient. Next is period of gestation. Period of gestation is the duration of the pregnancy expressed in completed weeks. So this is called period of gestation. In early pregnancy, the period of gestation is counted from the first day of her last menstrual period. But in later months of pregnancy, the counting is done from her expected date of delivery. Next is, how do you calculate the period of gestation? Period of gestation, why is important to know about the period of gestation? Because some complications occur in certain trimesters. So each trimester has different set of complications. In order to know the different complications and to give a better obstetric care to the woman, you need to know about the period of gestation. So what is the most reliable parameter to calculate the period of gestation? It is accurate LMP. You have to know the accurate LMP of the patient in order to calculate this. And if the LMP is inaccurate, then what do you do? When is the, yes, ultrasound? And in which conditions is the LMP inaccurate usually? If the woman is taking any oral contraceptive pills, or if the patient conceives immediately after the previous delivery, before the even, she forgets her dates, if the periods are irregular, if she conceives immediately after her previous pregnancy, even before her periods start. All these cases, you don't know her last menstrual period. So in such cases, ovulation is supposed to be delayed 2 weeks after a last menstrual period. So then we resort to ultrasound. And ultrasound in first trimester of pregnancy is more reliable for estimation of the gestational age. So first trimester pregnancy ultrasound is very, very important. And it is also known as dating scan. Next, you have to take her, whenever she comes for a visit, you need to ask her for her complaints. And whatever she complains of, they have to be noted categorically, and then she has to be advised accordingly. If she doesn't have any complaints, then you need to ask her about her sleep, bowel, appetite, and urination. And in the history of present illness, we have to elaborate on chief complaints. What are her chief complaints? What is their onset? What is the duration? What is the severity of the complaints? whether she is taking any medications for those complaints, and what is the progress of those complaints. So this all to be inquired in present illness. Next, in present pregnancy, what do you have to know in present pregnancy? You have to know about what complications arise in different trimesters of pregnancy, and then you have to treat accordingly. The first trimester, we most commonly encounter with hyperemesis, threatened abortions, that is hemorrhage, bleeding during the first trimester, hyperemesis, sometimes pain. So they have to be seen, and most commonly they complain of, most common complaint is either bleeding or vomitings. Then during the second trimester, she will be complaining of renal problems, pyelitis, increased frequency of urination, any urinary tract infections. All this she will be complaining of. During the third trimester, usually there will be symptoms of anemia, preeclampsia, and antepartum hemorrhage. So, depending on the trimester, you need to keep in mind what are the complications that are arising, and you have to inquire about all those things. Then number of previous antenatal visits should be noted. How many antenatal visits is she coming for? And this will tell you about the booking status of the woman. Why is it important to know the booking status? What is the importance of booking status of a woman? Because once you know whether it is a booked case or an unbooked case, then you will know. Because suddenly if you are faced with an unbooked case, mostly those women will have many untreated complications when they come in labor. If it is a booked case and if she is coming to you regularly, then you can plan her treatment, and later on the course of a pregnancy and her delivery later on. So that is the importance of booking status. Sometimes we get an unbooked case and the woman is very, very anemic. In such cases, it will become very difficult to manage such pregnancies. Next is, you need to know the immunization status. What is the immunization we give in pregnancy? What are the immunization that is important during pregnancy? Yes, TT, 2 doses of TT, and one more immunization you need to inquire about is TT. TT she has to take during 4th and 5th months, 2 doses of TT. And another immunization you need to inquire about is anti-D. If the woman has any abortions previously, and if she is Rh negative pregnancy, you need to inquire about anti-D immunization also. Next, you need to inquire about any other medication she has taken, or if she is taking her radiation exposure in the first trimester. These are all important because during the first trimester, there is the organs of the baby are formed during the first trimester, and any exposure to radiation or any medication which are contraindicated in pregnancy might lead to structural abnormalities in the baby. So this you need to inquire about this. Next is any medical surgical events, that if she has undergone any previous surgical events, we need to know about even them. Next is obstetric history. So what do you inquire in obstetric history? This is how you write the obstetric history. The number of pregnancies, first one, when did it happen, the year, date of the pregnancy, and how was the pregnancy? Was it a full-term pregnancy or whether it was a miscarriage? And if it was full-term, at what, in which, at how many weeks of pregnancy did she deliver? Even you need to note even that. And how was the labor? Whether it was uneventful or whether there were any complications during the labor. And you need to inquire in the pregnancy events each trimester, first trimester, second trimester, and third trimester. If she had any complications, followed by the pregnancy followed to full term or not, then how was the labor, whether it was a normal delivery or a cesarean, and And any purpurium, how was the purpurium? Any blood transfusion required or whether there were any infections. And next, we need to know about the contraceptives, whether she has used any contraceptives following her pregnancy. Next, about the baby, we need to inquire what is the weight of the baby, what is the sex of the baby, and how was the Apgar score of the baby at the time of birth, and whether mother has feeded the baby for, and if she has given breastfeeding, for how many months she breastfeeded the baby, and the immunization status of the baby. All these should be noted in obstetric history. If it was a miscarriage, whether evacuation was done and where was the evacuation done, whether it was institutional or non-institutional, and if she has used any contraceptives following evacuation. Then well covered whether antenatally, whether it was antenatal period was uneventful, and how was the labor, whether it was eventful or uneventful. Next, whether it was spontaneous, vaginal delivery, or whether any instrumentation is used or whether it ended in cesarean. So all these things you need to know and note down in obstetric history, because you have to plan this pregnancy accordingly. So finally, how do you sum up your obstetric history? It is summed up as Mrs. RL, whoever she is, Gravida 4, Para 2, Abortion 1, Live 2. So this is first, second, third, and now she is again pregnant. So total, what is her Gravida? It is 4, total number of pregnancies, irrespective of the period of gestation, whether it was a miscarriage at 8 weeks or it was a term pregnancy, she comes under 4th Gravida. But parity is only, abortions are not counted in para because they haven't completed the period of viability. So parity is only 2, para 2, and 1 abortion, 2 live births, and 2 live births. Sometimes I have told you they are written as even A, B, C, D. Here A is number of pregnancies which are carried to term. There are 2. 2 pregnancies which have been carried to full term. There are no preterm pregnancies, hence 0. 1 miscarriage, so 1. And number of live births who are still live at present, there are 2. So it can also be written as A, B, C, D. Then you need to inquire whether there is any long gap between the past pregnancy and this present pregnancy, because if there is a long gap, this pregnancy should be again treated as the first pregnancy, and careful supervision should be done during this pregnancy and labor. And the minimum spacing which we will advise to the couple is between the subsequent pregnancies is minimum of 2 years gap should be maintained between 2 pregnancies. So next, menstrual history. What is the importance of menstrual history in your case taking? It is, you have to know the cycle, the duration, the amount of blood flow, when was her last menstrual period, because you need to calculate the EDD from that. And how do you calculate your EDD? By Nagel's formula, by adding 9 months and 7 days to the first day of the last normal period, or by alternatively counting back 3 months from the first day of the last period, and then you have to add 7 days. Next, what is important in history? Next is past medical history. What are the medical illnesses you need to know about? Any urinary tract infections in the past, tuberculosis, any heart disease, epilepsy, all these you need to inquire. And next is any surgical history, previous history of any surgery, whether general surgery or gynecological, you have to inquire about them. Next is the family history. What is the importance of family history? There are some diseases which are hereditary in transmission, like hypertension, diabetes, any blood dyscrasias, and tuberculosis. Tuberculosis is not hereditary, but if anyone in the family has tuberculosis, then the woman is sure to contract tuberculosis. So you need to inquire even about the TB in any family members. And next is history of twinning. If the mother or sister has any history of twinning, there is a chance that this woman might be carrying twin pregnancy. Next is personal history. In the personal history, what do you need to know about? You have to inquire again her dietary habits. You need to calculate her body mass index. And next is calorie intake of the patient. In the personal history, how is her sleep, bowel, and urination, all those habits. Next, any contraceptives which she has used in her prior pregnancy, whether she is smoking, whether there is any history of smoking or alcohol intake, because these both are related to low birth weight of the baby. Next is any previous history of any blood transfusion, any steroid therapy, drug allergies, immunization against tetanus, or prophylactic administration of anti-immunoglobulin. All these should be taken in even personal history. Next, how do you examine a woman? How do you examine? You first start with general examination of the woman. We first, what do we note down? Whether she is, what do you say? How is her? First thing is, you will comment on her build and first you will talk about her build. And build, how do you know? You have to calculate her BMI. Yes, conscious, coherent. You have to know about that, whether the woman is conscious, coherent. How is she? Whether she is build, how is she? Moderately built or moderately nourished. Obesity, whether she is obese, average, thin. Because obesity is again, it is associated with hypertension, diabetes, and some other diseases. So you need to know, because complications during labor with like PPH can occur when the woman is obese. So you have to know about her build, her nutrition, whether she has a poor nutrition or good nutrition, because poor nutrition is again associated with anemia, low birth weight, preeclampsia, and some other conditions. Next, what is the height? Short stature is associated with contracted pelvis. So you need to inquire about the height. In Western countries, usually when the woman is 5 feet, it is considered she is short stature. But in India, short stature is considered when the woman is of a height of 4 feet 7 inches. 4'7" is considered short stature. Next, weight. Weight must be taken when the woman first enters your antenatal clinic with an accurate weighing machine, and the weight has to be repeated at every visit, and it has to be done with the same weighing machine so that comparison will be easier. What is the importance of weight? Because maternal nutrition and weight gain are directly related with the newborn birth weight. And when do you call that the woman is gaining weight rapidly? When she gains at least 0.5 kgs a week or 2 kgs in 1 month in later months of pregnancy, then you call that there is a rapid gain in weight, and it is one of the earlier manifestations of preeclampsia. Then you have to watch her for developing symptoms of preeclampsia. And if it is a weight, if it is stationary or falling, then it can then you have to need to know about whether the baby is growth retarded baby or whether any fetal death has occurred. In case of obese women, there is increased risk of complications both in pregnancy, labor, and also puerperium. So this is the ideal weight gain which should be expected. This ideal weight gain is based on pre-pregnancy BMI levels. If it is normal between 20 to 26, weight gain in this pregnancy should be only 11 to 16. If she is obese, then it should be less than 7. And underweight woman, she can gain up to 18 kgs. Next, in general examination, you need to see for pallor. Pallor, what are the sites you see for? The lower palpable conjunctiva, dorsum of the tongue, the nail beds. And jaundice, what are the sites? They are bulbar conjunctiva, undersurface of the tongue, hard palate, skin. Next, you need to even examine how is her tongue, teeth, gums, and tonsils, because they will tell you about any malnutrition. That is, if there is any presence of glossitis or stomatitis, then you can consider she is malnourished. Or any infection on the mouth, if it is present, it needs to be eradicated because it might cause infections in her puerperium. Next is neck. You have to examine her neck for any enlarged thyroid gland, if any lymph nodes are enlarged, and any neck veins are present. And slight physiological enlargement of thyroid is very common and mostly seen in 50% of pregnant cases. So you need not worry about any slight enlargement of thyroid. Then you need to check for any edema of the legs. And the site where you check for evidence of edema are the medial malleolus and the anterior surface of the lower 1/3 of the tibia. That is the area where you press with thumb for 5 seconds and you see for indentation. Next, you check for any varicose veins. And what are the causes for edema in pregnancy? They are either it can be a physiological edema or can be caused because of pathological conditions like preeclampsia, anemia, hypoproteinemia, any cardiac failure, any nephrotic syndrome. And dependent edema is always physiological, whereas facial edema or generalized edema, also called as anasarca, is first sign for a disease. And how does you tell whether it is a physiological or a pathological edema? What are the features of physiological edema? Because physiological edema occurs because of increase in the venous pressure in the inferior extremities because of gravid uterus presses on the common iliac veins. So it will cause edema. And what are the features of this physiological? How do you differentiate from pathological? By seeing the pressing on the ankle, and if it is of slight degree, yes, good, it will disappear on sleep or after 12 hours of rest. It is of very slight degree and present mostly in the ankle, confined to only one leg, that is mostly on the right side, and not associated with any features of preeclampsia, proteinuria or any other thing. Disappears on rest alone. And any other cardiac, renal and hematological pathologies have been ruled out. If it is not associated with any pathologies, then you can call it as physiological edema. Next, you have to check for vital signs like temperature, pulse, blood pressure. Blood pressure, how do you note for blood pressure? It is the disappearance of sounds rather than muffling. You have to note when the sounds disappear, not muffling. Is the best representation of the diastolic pressure during pregnancy. And next, after the vitals like temperature, pulse, blood pressure, you have to go for systemic examination. What do you see in systemic examination? Her heart, lungs, liver, spleen, and central nervous system have to be examined, and her breast should be examined because they will help in noting the changes of pregnancy, and you will be able to detect whether the nipples are cracked, depressed, so that you can start her treatment earlier so that she will not face any problems during her breastfeeding. Next, what is the condition of skin of her areola? You have to look for any fungal infections. Next, obstetrical examination. How do you do obstetrical examination? It is an abdominal examination where you have to do a thorough and systemic examination beyond 48 weeks. And this obstetrical examination is done to diagnose what you have to know about. What are the main things you need to know about the lie? What is a lie? Lie is the relationship of the long axis of the fetus to the uterus, centralized uterus or maternal spine. This here, the long axis of the fetus compared to the maternal spine, or this is a centralized uterus. This is not a centralized uterus. In such cases, you cannot compare the lie with long axis of the uterus. Only when the uterus is centralized, you can compare the long axis of the fetus with that of the uterus or with that of the maternal spine. So in this case, you call this lie as longitudinal lie. Here it is oblique lie when compared to maternal spine. It is oblique lie. Here it is, when compared to maternal spine, it is a transverse lie. So this is called lie. Next, what is presentation? Presentation is the part of the fetus which will occupy the lower pole of the uterus is called presentation. See, this is cephalic presentation where this part will occupy the lower pole of the uterus. Even in cephalic presentation, there are various varieties of cephalic presentations. Here, it is completely flexed head, so it is a vertex presentation. Here it is a vertex presentation, but it is deflexed head. Now here it is not the head that is presenting, but the brow part. This part is the presenting part. So we call it as brow presentation. Here we call it as face presentation. So these are various types of vertex presentations. So the presentation is where the comparison with presentation is the part of the fetus that occupies the lower pole of the uterus is called presentation. Next, what is position of the fetus? Position is relationship of the denominator to different quadrants of the pelvis. What is a denominator? What is a denominator? It is relationship of the denominator to different quadrants of the pelvis. Denominator is the prominent bony portion in the fetal. See, this is a well-flexed head. So, what is the prominent bony portion which is present in the lowermost pole of the uterus? It is the occiput. So, here the denominator in vertex presentation is occiput. Whereas in a deflexed head, it is the sinciput. Sometimes sinciput can also become the presenting denominator. Whereas in brow presentation, it is the brow. This is the forehead. This is the frontal bone will become the denominator. Whereas in face presentation, this nasal bone will become the denominator. So it is the lowermost bony structure which is related to different quadrants of the pelvis is called the position of the fetus. Next is attitude. What is attitude? The relationship between different parts of the fetus to one another. Universal attitude is always flexion. So how the fetus lies in the uterus like this. This is the flexed attitude of the fetus. This is called flexion attitude of the fetus because all the parts are in flexed position. So this is how you see whether we look for position, the arbitrary bony point which is in relation to different parts of the pelvis. You need to know because you need to know whether it is occipito-anterior position or occipito-posterior. So occipito-anterior, there are also other positions like right occipito-anterior, left occipito-anterior, then LOT is left occipito-transverse, right occipito-transverse, ROP and LOP, occipito-posterior. So you need to know because you need to plan the labor accordingly. Any doubts regarding lie, presentation, position, attitudes? Where you haven't understood so that I can repeat again? Okay, next we'll go for yes. Okay, I'll just tell you about again live presentation so that you can again see what is a lie. Lie is relationship of the long axis of the fetus to that of the uterus which is centralized or to the maternal spine. Here in this picture uterus is in central position. In this picture the uterus is slightly deviated to the left side. So you cannot call this as centralized uterus. In such cases you cannot compare the long axis of the fetus to that of the uterus. Here you have to compare the long axis of the fetus to that of the maternal spine. So in this, the long axis of the fetus is lying in parallel to that of the maternal spine. This is the maternal spine. So this is called as longitudinal lie. Here also it is called as longitudinal lie, but the axis of the fetus, long axis of the fetus is slightly oblique to that of the spine. So in this, you call this position as oblique position. Even here it is oblique. This is here the uterus is centralized and uterine axis is also in line with that of the maternal spine, but fetus is in oblique position. Here even the uterus is not, the uterine axis is also not in line with the maternal spine. Here uterine axis is in line with the maternal spine, but fetus is oblique. Here both fetus as well as the uterine axis are in oblique position. And here the fetal axis is in transverse position. So whether the lie is longitudinal lie, oblique lie or transverse lie, whether the fetus it depends on the axis of the fetus in comparison with the maternal spine. So accordingly you will tell whether the fetus is in longitudinal position, oblique position or transverse position. That is lie. Next is presentation. Presentation is that part of the fetus which will occupy the lower uterine pole is called presentation. Usually, if the vertex occupies the lower uterine pole, you call it as vertex presentation. If breech occupies the lower uterine pole, you call that as breech presentation. Next is the position. What is position? Position is the relationship of the denominator to different quadrants of the pelvis. Is called position. See, this is the position, occipito-anterior position, where you take occiput as the denominator, that is the arbitrary bony fixed point which is occupying the lowermost pole of the uterus. And what is the relationship of that occiput with various quadrants of the pelvis? These are the various, this is how a pelvis looks like, and its relationship to these all quadrants of the pelvis is called as position. If the occiput is occupying anteriorly, that is if it is present below the symphysis pubis, it is called as occipito-anterior. If the occiput is occupying the posterior position, that is the hollow of the sacrum, it is called as occipito-posterior position. In this occipito-anterior also, the occiput can be towards the right. There are other positions like right occipito-anterior and left occipito-anterior position. And even this right occipito-posterior and left occipito-posterior, when the occiput occupies is present on the sacral joint, sacroiliac joint. If it is present on the right sacroiliac joint, it is right occipito-posterior. If it is on the left sacroiliac joint, it is left occipito-posterior position. And if the occiput is transverse, it is the transverse position. So this is the importance of position. Next, last is attitude. What is attitude? It is relationship of different parts of the fetus to one another. So how the uterus is how the fetus is in the uterus. This is the relationship of different parts of the uterus to one another. So the universal attitude is always flexion. If there is any extension, there will be difficulty in delivery of the baby. That is why in this, you can see this is a flexed head. When it comes to this, it is slightly deflexed head. When it is here, it is moderately deflexed head. But when it comes to this position, face presentation, it is extremely deflexed head. So universal attitude is always flexion. Even the head should be in a flexed position. So what are the preliminaries for abdominal examination? You have to take a verbal consent from the woman. She is asked to empty her bladder, and she should lie in a dorsal position with her legs slightly flexed. Abdomen should be fully exposed, and the examiner should stand always on the right side of the patient. Next, what do you do? First is inspection. On inspection, what do you know? How is the uterine ovoid, whether it is longitudinal, transverse or oblique. I have told you this will depend on the lie of the baby, whether the baby is in longitudinal, transverse or oblique positions. Next, the contour of the uterus, whether there is any fundal notching is present, and anterior wall, whether it is flattened anterior wall or whether it is a convex. Next is how is the shape, whether the shape of the uterus is cylindrical or spherical. And where you have to even note on any undue enlargement of the uterus which is seen in case of polyhydramnios or twins. What are the pigmentary changes in the skin like linea nigra, stria gravidarum? Next, you have to look at the skin whether there are any infections or not, and any incisional scars like previous any cesarean scar is there or not. And you have to look for the hernial sites. You have to inspect the abdomen for all this and whether all the quadrants of the abdomen are moving equally with respiration or not. You need to comment about all these things in inspection. Next one is palpation. Palpation is you need to first measure the height of the uterus. How do you measure the height of uterus? With the ulnar border of your hand. This is the ulnar border of the hand, and of the left hand, which is placed on the uppermost level of the fundus, and the approximate duration of the pregnancy is ascertained in terms of weeks of gestation. See, this is how the ulnar border is placed at the fundus, at the height of the fundus, and you have to measure like this. If it is just palpable above the pubic symphysis, it is 12 weeks. Then at the umbilicus is 24, and between the umbilicus and pubic symphysis, it is divided into two parts. The lower one is the 16 weeks, above one is the 20 weeks. Next, when it is at the xiphisternum, it is 36 weeks, and between these two, again it is divided into two parts. Just above the umbilicus, 28 weeks. Just below the xiphisternum, it is 32 weeks. And how do you know whether the 40 weeks? 40 weeks is, again the uterus will become 32 weeks in size, but there is enlarged, it is enlarged transversely. That is, it will occupy, there is fullness of flanks. If it is present, you can call it as a term pregnancy. Yes, fullness of flanks. Then you call it as a term pregnancy or 40-week pregnancy. This is how you measure the fundal height. And next you have to note down even the symphysiofundal height, where in centimeters it will correspond with the weeks of gestation. The height in centimeters. Next is you have to take even the abdominal girth. Next, conditions where height is less than the period of amenorrhea, when they are mistaken dates, scanty liquor, growth retardation, fetal death. Next, where the height is greater than amenorrhea, mistaken dates, twins, polyhydramnios, big babies, any pelvic tumors, mole, or concealed accidental hemorrhage. Next are the obstetric grips. What are the grips? First one is the fundal grip, where the palpation is done facing the patient's face, where the whole fundal area is palpated with both the hands. Laid flat on it to know which pole of the uterus is lying in the fundus. If it is a broad, soft, irregular mass, it is breech. If it is a smooth, hard, globular mass, it is head. So, see, this is the fundal grip where you place the entire, both your hands flat on the fundal area and you palpate. If it is a soft mass, it is breech. And if it is very hard, globular, it is head. In transverse line, no poles can be palpated. And lateral or umbilical grip, where the palpation is again done facing the patient's face, where the hands are placed on either side of the umbilicals to palpate one after the another. You have to palpate the sides and also the front of the uterus to note the position of the back, the limbs, and the anterior shoulder. Back is seen as a smoothly curved surface with resistance. The limbs they are empty with small knob-like irregular parts are felt. So that is the limb side, and where it is smoothly curved and resistant, it is the back. The position of the anterior shoulder is sought for. You need to know whether it is lying near the midline or away from the midline. So this is how it is the lateral grip or the umbilical grip, where you palpate the both sides. The back is felt as smoothly curved and resistant and small knob-like structures, and this side is relatively empty, is called the limb side. And this is the third grip, where you place your thumb and 4 fingers in the lower pole of the uterus and you palpate. That is called the Pawlik grip, where examination is again done facing the patient's face, where the overstretched thumb and 4 fingers of the right hand are placed over the lower pole of the uterus, and ulnar border of the palm and the upper palm are placed on the upper part of the symphysis, and you need to feel whether the presenting part should be grasped and look for any mobility. And side to side should be tested. This grip is also empty in case of transverse slide. Next is the pelvic grip, where here only in the pelvic grip, the examination is done facing the patient's feet, where the four fingers of both hands are placed on either side of the midline in the lower pole of the uterus, parallel to the inguinal ligament like this, and you have to palpate. And what will you see in this? When the fingers are pressed downwards and backwards, and you approximate the fingertips, you will know what is the part that is occupying the lower pole. Yeah, you will know. If it is a head, then you will know all these parts, the presenting part, whether the cephalic prominence is palpated, and you will note the relationship with the limbs back, then the attitude. Because by noting the relative position of the sinciput and the occipital poles, you will know what is the attitude, whether it is in a flexed attitude or deflexed attitude. Next, the engagement. You will know the presence or absence of sincipital and occipital poles, and whether there is any convergence of, see, this is how. If it is the fingers are diverging, it means the head has entered the pelvis. That means the head is engaged. And if the head, if the fingertips are converging, it means the head can be still palpable and it is not engaged. So you will also note engagement. Next is auscultation, where the fetal heart sounds are best audible. They are audible through the back. And where is the maximum intensity? In case of cephalic presentation, it is below the umbilicus. But whereas in breech presentation, it is around the umbilicus. In vaginal examination, why is it needed? It is done first to diagnose the pregnancy and to note whether the size of the uterus is corresponding with the period of amenorrhea, and to exclude any other pelvic pathology. And vaginal examination is not done in case of any previous miscarriage, any bleeding, if the patient reports any hemorrhage during this pregnancy or bleeding. You should never do a vaginal examination. So what do you do in vaginal? You have to inspect by separating the labia and index with the thumb and forefinger. Then you will you will note if there is any vaginal discharge. Next, speculum examination, a bivalve cuspo speculum is introduced, and if any swab should be taken, it has to be taken. Next is bimanual examination is done with 2 fingers of the right hand, and you have to note the cervix, uterus, and adnexia. So this is how vaginal examination is done. Next, what are the investigations you do routinely? You have to do bloodly investigations like hemoglobin, hematocrit, grouping, typing, then random blood sugar, VDRL, and look for in case there is any history of hemoglobinopathies. You have to do even them. Next, urine is looked for proteins, sugar, pus cells, and if any significant proteinuria is found, then you need to collect a clean catch midstream urine specimen is collected and sent for culture sensitivity test. Next, in indicated cases, you need to do a pap smear. Speculum examination will be done if the woman complains of any vaginal discharge. To note the speculum, to note the type of discharge, you can do a speculum examination. It is not contraindicated in case of pregnancies. And even if the woman is complaining of any leaking per vaginum, even in that cases, in cases of PROM, you need to do a speculum examination. And what are the special investigations you do? You do serological test for hepatitis B, HIV, and genetic screening, that is triple test, and maternal serum alpha fetoprotein test. It is done between 15 to 18 weeks to identify the mothers who are at risk of carrying a fetus with neural tube defects, Down syndrome, or any other chromosomal abnormality. Next, ultrasound examination is done during the first trimester. TVS or TAS can be done. It is called dating scan. Next is booking scan is done between 18 to 20 weeks, where a detailed fetal anomaly survey is done. And any other structural abnormalities, whether they are present or not, you have to look, and even placenta is localized. Next, you will repeat the investigations like hemoglobin should be repeated at 28 and 36 weeks. And urine is tested for protein and sugar at every antenatal visit when the woman comes to you. Next, why do we need to know that? So that we can plan the woman for subsequent visits and advise her accordingly regarding her medical intake. We need to advise about her folic acid, iron intake, dietary habits, and after that we need to even tell her how frequently she has to come for visits. Generally, checkup is done at an interval of every 4 weeks for up to 28 weeks, then every 2 weeks for up to 36 weeks. Hello. Vachestunna. I can. Then checkup should be done every weekly till delivery, and according to WHO, she can come for only 4 visits. The first visit can be in the second trimester at around 16 weeks. The second between 24 to 48 weeks. Third visit can be 32 weeks, and fourth at 36 weeks. And this is according to WHO. There can be only 4 visits. But if she is willing, then she can be called every 4 weeks, and from 36 weeks onwards every 2 weeks, and after 36 weeks every weekly till she delivers. So thank you, Jai. Any doubts or any queries you have, you can ask me. Yes. They are saying that COVID is vertically transmitted. There is vertical transmission of COVID, but it may not be affected so much. Okay, then the time is also over. It's already 12 now.